Good afternoon, everyone. Before your well-deserved coffee break, let's dig a little bit deeper into pancreatic conditions with my thesis, New Insights on Secretin-enhanced MRCP in Pancreatobiliary Pathologies. My name is Emese Fürst. I'm a second-year gastroenterology resident at the Institute of Pancreatic Diseases. So we're working with a really specific patient population, and our vision is to lie down and improve diagnostic algorithm concerning these patients. And to achieve that, our mission is to make good use of all available diagnostic modalities in different conditions which affect them. In order to achieve this goal, or this vision, we have specific goals set ahead of us. The first one is the utilization of secretin-enhanced MRCP in all pancreatobiliary pathologies, which will be a systematic review and meta-analysis started in September this year. And their second project concerning the risk factors, the predictive risk factors, and the impact on the outcome of acute pancreatitis of the disconnected pancreatic duct syndrome. So let's talk a little bit about our first project regarding secretin-enhanced MRCP. The first question should occur, why? Why are we interested in it? Well, let's imagine, for example, me who's working with patients with different pancreatobiliary pathologies. There are a vast ton of different imaging modalities and functional tests available. Some of them, like the cross-sectional imaging modalities, are non-invasive, but then we have the invasive EUS and ERCP as well. And then there is the odd duck, the secretin-enhanced MRCP. We do know that it can improve the visualization of the pancreatobiliary tree, and it can also provide functional information while being non-invasive. There are no apparent guidelines yet when exactly to use this method. So our aim is to study the diagnostic accuracy of secretin-enhanced MRCP in different pancreatobiliary pathologies, and we hope to identify a population or a section of a population that benefits from using it. And maybe we can find the answer when to use it, or if to use it at all. So our clinical question regarding the diagnostic test accuracy of secretin-enhanced MRCP is this. So our population will be different pancreatobiliary conditions, people with different pancreatobiliary conditions who undergo our index test, secretin-enhanced MRCP. The reference will be the gold standard diagnostic tool for each specific condition. So we will try to see whether secretin-enhanced MRCP is better than ERCP in the specific conditions or fecal elastase or so. And the outcome measures will be specificity and sensitivity. Our hypothesis is that there is a population that benefits a little bit more than others when a secretin-enhanced MRCP is done. And we hope to change the protocol for investigation. We hope to avoid some unnecessary testing, would it be invasive or not. We conducted a systematic search in 3 medical databases on the 22nd of November with the relatively small search key, because we did not want to miss out on any articles regarding secretin and MRCP. So in advance, I would like to show 3 key articles for you and to show you what limitations we have. So most of all, there is a little scarce literature on secretin-enhanced MRCP, although it has been with us since the late 1990s. Key articles are hard to find because most of them are retrospective reviews of radiological database. There are a little bit too much time between the diagnostic tests, would it be ERCP or secretin-enhanced MRCP. There are very little blinded comparative studies, and even if there are, the case numbers are small. But we would like to see whether we can. We are sure that we can conduct meta-analysis, although these will be small in numbers. So we found a little bit more than 1,100 articles. And after the duplicate removal, 780 left. And I have two amazing TDK students who just finished the title and abstract selection, so we are ready to start full text selection in a day or so. Our next topic regarding the risk factors and the impact of outcome of disconnected pancreatic duct syndrome in patients with acute pancreatitis, long title I know, but it would be a prospective cohort study regarding patients with acute pancreatitis and the very serious but often overlooked complication of acute pancreatitis. So disconnected pancreatic duct syndrome, the name implies there is some injury to the main pancreatic duct, which can lead to forming of fluid collections and even Waldorf necrosis. In the literature, the incidence has been variable, ranging from 16 to more than 46%, and the frequency is even higher in patients with acute necrotizing pancreatitis and patients with Waldorf necrosis. Why is it important? It's important because it increases the rate of ICU admissions, interventions, whether it be endoscopic or surgical, and altogether it influences the overall outcome, the length of hospitalization, and the treatment costs in acute pancreatic patients. Our aim is to determine risk and prognostic factors for developing DPDS and investigate its effect on the outcome of acute pancreatitis. So to summarize our aims, we have two ongoing projects. The first one regarding secretin-enhanced MRCP should be done in early summer, and our second project would be done in a year or so. Thank you for your attention, and as the French-Romanian playwright Eugene Ionesco once said, it is not the answer that enlightens, but the questions. So I'm welcoming your questions here.
Thank you very much, Emese, for this very nice presentation. Do we have questions from the audience? Yes, we do.
Hi, congratulations on your presentation. I was curious about the availability of this technique in Hungary. Like, do you use frequently?
Well, the short answer, the simple answer is no. Secretin-enhanced MRCP is not yet available in Hungary, but we talked to one of the best pancreatic radiologists in the clinic, and she said that she would really love to have this method. So after our systematic review and meta-analysis, maybe we can convince people that it is something that we should invest in.
In the meantime, I would like to ask you, when do you consider, this is regarding your first project, when do you consider ERCP as a diagnostic tool?
Well, ERCP, or as the gold standard diagnostic tool, is still in, for example, pancreatic divisum, or there are some cases. I know that EUS is a less invasive technique, and it is, more widespread than secretin-enhanced MRCP, but for example, pancreatic divisum, ERCP is still the gold standard. So we would like to reduce the number of invasive diagnostic methods. I know that diagnostic ERCP has been less and less frequent nowadays, but for some reason, the gold standard in, for example, pancreatic divisum, it still stays.
A very nice lecture and research. Unfortunately, we do not have secretin in Hungary, but we make the diagnosis of imputed bile duct syndrome. How much the secretin increases the sensitivity and the specificity or the accuracy of the diagnosis?
Actually, it depends on the specific condition, and the literature has been very variable. So some cases we've seen, case reports and small number studies say that it can increase the accuracy up to 100%, but then there are some other studies who say that, oh, come on, there's no difference, or it's even worse. So that's why we would like to conduct this study to make it clear and see whether there's future for secretin-enhanced MRCP, or we should just stick to conventional MRCP and other diagnostic techniques.
And how much does it depend on the MRI itself, because there are different generations of MRI. So if you go back to 10 years, the sensitivity of the MRI itself is considerably different.
Secretin-enhanced MRCP has been with us since the late 1990s, where only 1.0 Tesla MRIs were available. But then with the radiologic revolution, most studies we've found has been conducted on either 1.5 or 3.0 Tesla. So we could do a subgroup analysis based on these as well, or we can say that it is a limitation because we cannot really compare a 1.0 Tesla to a 3.0 Tesla, because it's like comparing a Trabant to a Ferrari, basically.